Okay, and how so?
I don't know, is this chart, kind of the left and right side chart, of the sympathetic, parasympathetic, and then
Okay, okay. Yeah. Okay, did Dr. McNeil talk about any pathophysics? No. Okay, so these are, so the focus up until this point has been primarily on the sympathetic nervous system and the renin-angiotensin system. That's what most of our therapy has been directed to. So atrial natriuretic peptide came out probably 20, 25 years ago. People started recognizing that there were these vasoactive peptides. So BNP then probably in the last 10 or 15 years became something that people started looking at in terms of diagnostic. You know, is it elevated? What does that mean? Stretch. Right, stretch and ventricle. So usually it goes along with heart failure. The higher the BNP usually goes along with worse failure. What would be a normal BNP? Less than 100. So if you see it in 1,000, you know there's something going wrong. So there's 3 natriuretic peptides. Can you name them?
ANP, B type.
ANP, BNP, CNP. So the A is primarily activity is where? Atrium. That is thought to be a kind of a peptide that really maintains the health of the atrium. It does lots of different things. Helps with blood flow, helps with maintaining the health of the myocytes. It works against or it prevents remodeling of the atrium. So it's thought to be a ever-present help to the atrium. Now the BNP is primarily what? Ventricle. It is thought to be more a stress hormone, that when it goes up, it's telling you that there's problems in the ventricle. The CNP, I don't know that much about. I don't know exactly, it's out there. I can't tell you a lot about what it does. They are not only located in the heart, there's also these peptides are also in the kidney. All right. So this system, that NP system, if you look at the left side, many good things it does. So it's a natural natriuresis, diuretic, so it decreases renin secretion. What is renin? It's produced by what? Kidney, and it does what? Angiotensin. Okay. So it decreases angiotensin 1 production, vasodilation, so it decreases blood pressure, so stress, endothelial permeability, maintains the endothelium, the little vessels, decreases hypertrophy, decreases fibrosis, and decreases sympathetic outflow. So this drug that has come out, the sacubitril, it inhibits the peptidases that break those down. So it allows them to stay around longer. So you get the benefits of those actions while at the same time while you're affecting the renin-angiotensin syndrome with your ACE or your ARBs, and you've got an ARB in that Entresto, right, that combination. So that drug affects both sides. Then your beta blockers are affecting the sympathetic system. So now we're hitting 3 different areas that have effects on the health of the heart and the functioning of the heart, the structure of the heart. Does that help?
Yes.
Okay. So they've been around, I don't know, 5 years. So now there's accumulating evidence that these drugs even decrease morbidity and mortality to a greater extent in some people than you see with ACE and ARBs. ACE are still the foundation. They have the most data behind them. They've been around the longest and probably one of the safer ones to use. Okay, so we're still, I don't see ACEs being dethroned for a while. They may eventually, this may become the drug of choice. I don't know. It's really, it has moved up quite a bit through clinical trials in terms of use in heart failure. Okay. And then ARBs are usually going to be secondary to ACEs if they can't, if the patient can't tolerate. All right. So any questions about these? There's one other. I reposted this. This is your PowerPoint version 2 on D2L. So this just gives you another kind of visual. So they put it in green to show you that it's a promoter, and whereas our ACEs and ARBs are inhibitors of that system. All right. Okay, let's look at the aldosterone receptor antagonist. So spironolactone's been around forever, probably 50 or 60 years. Long time drug. And it is found to be very helpful in heart failure, especially in some cases. It has data behind it in terms of improving, decreasing morbidity and mortality, so improving longevity of people who have heart failure. Okay, so this class of drugs. So this just walks you through and reminds you. You all are usually able to recite this. So this one just reminds you where everything comes from and the transformation of angiotensinogen eventually to get to aldosterone, which is what we're focusing on with this class of drugs. Okay. So this drug works in the collecting tubules. So you've got about 4 sections of the nephron that work on either water, getting rid of water, or reabsorbing water, or getting rid of sodium, or keeping sodium. So this is kind of the last place, so collecting tubules. This is the ones that all come together and eventually form your ureters that then take fluid out. So, just to orient you, this is the lumen of where urine is. This is blood, and these are the cells of the collecting tubule. So aldosterone, which is made where? Adrenal cortex. Okay. In the top layer, the glomerulosa, and aldosterone is classified as what type of action? Mineralocorticoid. Last part tells you it's a steroid base. Most of the hormones have a steroid complex in them, and then the body does different additions which then give it its action. So aldosterone circulates in the blood, enters those collecting tubules, and you see that there is a aldosterone receptor in that cell. Okay. Like a lot of steroid hormones, it affects nuclear. It goes to the nucleus, has a receptor in the nucleus of that cell, and it will change the way that cell produces peptides. So normally, let's look at this. Normally, sodium's coming down through that urine. The collecting tubules will bring sodium in, and excrete potassium in the urine. Okay? Maintains neutrality, right? Okay. So we're going to reabsorb sodium. We're going to throw potassium out. Notice chloride's here. Chloride kind of has a free rein. It can just pass through. But the body is also, the kidneys are your last organ that helps to maintain acid-base. We talked about that. Y'all done acid-base metabolism? Okay, status. So the other, so here you've got an exchange of bicarb for chloride. So the blood will bring the bicarb back into the blood, because that's one of the basis of our initial buffering system is always bicarbonate in the blood, right? So we're gonna exchange these ions, and then we're working with these ions through pumps that require energy, because we're always going against a gradient. So it's not a passive diffusion, so if you want to be able to go against a gradient, the cell has to put energy into it. All right, so what aldosterone does is it affects this pump system, and it causes the body to either get rid of sodium or to bring sodium back in. Doesn't that make sense? Because we talked about aldosterone as part of that RAS system, is that it is trying to increase volume, right? Okay. So the way it does it is it doesn't affect so much free water, is it affects sodium, because wherever sodium goes, water will follow. Okay. So that's the way that the aldosterone can increase that circulating volume. Even though it's a maladaptive response to what is going on. The body's already fluid overload, but effective circulating volume is diminished, right? And the kidneys are watching that all the time. And when circulating volume goes down, then the kidneys, then that renal system is activated. So when we give an aldosterone receptor antagonist, it sits on that receptor, so this isn't going to happen to the same extent. So then what's going to happen is we're going to excrete more sodium, so you can measure that in the urine, and we're going to increase our potassium reabsorption. So you can see why these drugs increase potassium in the blood, right? Okay. Mechanism makes sense? Okay, so that's what we're doing. And so then where sodium goes, that water's going to follow, so we're going to excrete free water as well as sodium. Okay. So under pharmacologic effects, third or fourth down, spironolactone has two big metabolites. One of them is canrenone. Canrenone gives it its major metabolic effect, or pharmacologic effect. It has a very long half-life, so it allows us to dose the drug once a day, usually. Spironolactone itself has a fairly short half-life, but these two have long half-lives. Spironolactone is a non-selective aldosterone receptor. You have these receptors that are similar throughout the body, and that gives us some of our side effects with spironolactone. But eplerenone is selective. So you don't see the side effects with it that you do with spironolactone. It's more expensive though, not used as much for that reason. So under indications and expected clinical outcomes, the expected clinical outcome when you add it is that it will decrease morbidity and mortality. It is indicated under that second bullet, class 2 through 4 heart failure, left ventricular ejection fraction less than 35. Now, the new guidelines in 2017 came out and said for those with preserved heart failure, that those folks may benefit from the addition of an aldosterone receptor antagonist. That's new. So that is it has been shown to improve their longevity. Next page, contraindications, acute renal insufficiency. Some of the reason is you can't get the drug delivered. That's a lot of the reasons why we don't use these diuretics in heart or in kidney failure is we just can't get them to the site of action. There's a video, I verified this one, it is a good one, I would recommend it. Administration, so this one's important. It's I put it in red, but for you all, it's still in black and white. Creatinine should be 2.5 or greater. Do you know a normal creatinine? 0.6 to 1 is normal. So these folks have significant renal insufficiency. In men, or less than 2 in women. So that would be a glomerular filtration rate of 30, probably below 30. You wanted at least 30 mils per minute and above. That is like a class, that's like a stage 3 renal failure, renal insufficiency. So it's a great decrease in their ability to filter, but it's enough that we can still get drug action. What's a normal GFR? Probably in you all, over 100. Okay. As people age, then that goes down. The other is potassium. So you got to look at serum creatinine, you have to look at potassium, and you want them in normal range. So you want a potassium in the normal. What's a normal potassium? Y'all haven't had potassium? In lab mass? Really? Okay. So 3.5 to 5 is normal. Some you might see 3.3, but I just always remember 3.5 to 5. The reason for variance is that you will, when you get into your labs in different hospitals, they will have reference ranges. And so we'll always look at the reference range for the lab that ran your lab. Okay? So there may be a little bit of variance in different labs. You start low, so with spironolactone, 12.5 to 25 a day is the usual starting place. Usually we can dose it daily. We might go up to as high as 50. I'm not going to ask you to know the dose on those. So monitoring parameters, potassium, serum creatinine. Okay. Or anytime you've got changing status with a patient. Often if their heart is failing, their kidneys may be in trouble as well. If you add a drug that has a potassium effect on potassium, then that needs to be followed. Sometimes different people are adding different drugs. So you may be the person, if you're in primary care, see that they are on 3 drugs that affect potassium status. So always important to check that potassium. I put down salt substitutes because they are often recommended to people in heart failure. They are a potassium salt. People can get into a lot of trouble if they're using a potassium substitute with an aldosterone receptor antagonist. And it will say on there, like this is Morton's, so it'll say salt substitute. So when you're in the grocery store, go by the spice section, look at the salts, pick it up, and look at the back. It's potassium chloride. So strategies to minimize. One is just always be aware, always be looking. Anytime I start to see people on potassium, drugs that affect potassium status, I'm always looking as what else are you on? Okay? People can buy potassium over the counter. It's a low amount, but they can still buy it. So I always ask them, buy anything over the counter? Always, never forget their power to take information they know, apply it, and try to self-treat. Kidney function, potassium level. Risk of hyperkalemia, again, is when you use it with an ACE inhibitor. So all these people are going to be on an ACE, an ARB, or an ARNI, okay? So they're all going to have potassium status problems, all of them. If they're on a large amount of diuretic, let's say they have a significant degree of renal insufficiency, then what did we say about the furosemide dosing in normal versus renal insufficiency? You have to go higher. So normal dose of furosemide, or max single dose of furosemide in someone who has normal renal function is 40 to 80. And then those who have renal insufficiency, yesterday I told you it's 160 to 200, or 80 to 160. So those folks are going to need potassium supplement. With the higher the dose of diuretic you give, usually they will need some kind of supplementation. Now, when you put them on a drug like this that helps them retain potassium, then you may need to reduce, you will need to reduce the dose of the potassium supplement. If they're on a low amount, you may need to take it off. So it isn't a contraindication to have somebody who is on this drug, spironolactone, and also potassium supplement if they're on large doses of furosemide. I cannot tell you how important this is and how often I see it cause trouble because people aren't paying attention. Maybe it isn't the focus of the day, maybe it isn't what they're looking at, but eventually it will cause trouble. The more the decompensated or the more borderline they are, the more likely they are to have problems. Side effects. So number one side effect is hyperkalemia. Okay. Avoid the triple combination that I just talked about. Renal function, always monitoring it. Gynecomastia. So spironolactone is one of the most common causes of gynecomastia in men. If you have a man comes in and they've got gynecomastia, you got to look for spironolactone. Another would be cimetidine. It's not used very often, but it's H2 receptor antagonist that also has that. About 10%. It's very high. And then hyponatremia would be another reason. Dose too high. Sodium restricted. Okay, questions about those? Okay, hydralazine nitrate combination. So this is a drug called Bidil. Came out probably 7 or 8 years ago. It is targeted primarily for African Americans. It is indicated when they cannot take an ACE or an ARB or an ARNI. So let's say they've had angioedema. Let's say they've been non-responsive. For some reason they can't tolerate it or use it. This would be a substitute. So you've seen nitrates before, and hydralazine is a very old drug, 60, 70 years. Been around a long time. Used to be the mainstay of therapy for hypertension. It is a very potent vasodilator. So and it's arterial. So it's arterial vasodilator. What kinds of things are you think it's how is it helping the heart? No. It's an arterial vasodilator. So what's it reducing? Afterload. Afterload. Okay. The nitrate, what's it doing? It's affecting preload. Okay. So this combination is powerful. It can really reduce the load on the heart. African Americans have different sensitivities. They are more salt sensitive. They do better with higher potassiums in their diet. Did Dr. Britton talk about this? They're usually not big renin output, so they usually don't respond to ACE inhibitors to the same extent that other ethnic groups do. So they are a little bit different. You will see in the guidelines, like in your American Heart Association calculator for risk, it has African American as part of one of the criteria that you enter. So they're different. Their blood pressure is more resistant to treatment. They're a harder group, and they're a higher risk for heart failure, higher risk for diabetes. So a lot of things that affect the heart are in that group, higher risk. So this drug, powerful vasodilation, both the venous side and arterial side. It's been shown to reduce morbidity and mortality. I have never seen it used in a Caucasian population. I don't know if there's any data there for that. If you've got people who can't tolerate the other as well, or ACE inhibitors as well. So where do you think the problems are gonna be? What's gonna be your big side effect?
Headache.
Well, hypotension, what would be the other one? Tachycardia. Yeah, you could see headache, tachycardia. Vasodilators, always go back and look at your determinants of blood pressure. Vasodilators always have reflex tachycardia as one of their main problems. The other is that they are always potent, they always are fluid retainers. So most of your patients are going to be treated with a diuretic anyway, so usually we're working with it anyway. Contraindications was don't use phosphodiesterase inhibitors. Anything we talked about with nitrates as a contraindication would be a contraindication here. The other downside on this is that hydralazine has a very short duration of action. So it has to be dosed in the past, and this is one of the reasons it fell out of favor, is that it had to be dosed 3 to 4 times a day. And this drug has to be dosed 3 times a day. Nitrate's the other, short duration of action. So 3 times a day. You can separately give these drugs, they're cheap. They can be used separately for the same effect, or you can use the combination. Combination's going to be more expensive. Often what people will do is start separately, titrate them to effect, and once you've got them on a stable dose, stable response, then switch them over to the Bi-Deal, especially if there's an insurance problem. Okay, monitoring parameters, blood pressure, heart rate. The other thing is hydralazine is an old drug. Oh, let me go back to one other thing. So the other problem with hydralazine is that with that decrease in heart rate, blood pressure, you can also see increase in angina symptoms. So if they have angina as well, if they're not getting good perfusion, they may also develop complaint of greater anginal symptoms. Okay, under monitoring parameters, the last one is hydralazine is one of those drugs that induces a type of lupus. Most of the old drugs that did that are not around anymore. Procainamide that we talked about, a 1A antiarrhythmic, can also do that. Discoid lupus is lupus that is usually confined to the skin. It's usually face and back or trunk. Okay? So you don't get the kidney and the musculoskeletal and other problems that we see with systemic lupus. So this is usually a skin lupus. Fairly common. So if they develop these types of lesions, then doing an ANA titer to look for immune responses is warranted. We'll talk about this again when we get to musculoskeletal. But I want you to be aware, because it's coming back into vogue to use this, this will happen. Adverse effects, we talked about the CNS, GI, always, hypotension, and the lupus. Questions about those? The last one is, did you all talk about this one? Ivermectin? This is a new one. This is a drug that works on the SA node. Now the SA node has different channels, different currents than you see with the Purkinje fibers that we talked about there, the action potential. So the action potential in the SA node is different. And there is this IF current that is influenced by this drug. It has a specific indication. It's for people whose resting heart rate still remains elevated despite the use of a beta blocker. This is a drug that can be used to further lower it. It's the only indication I know of it. It's not included in any of the other antiarrhythmics. We don't use it for any other arrhythmia. Okay. Last one is digoxin. Digoxin, again, been around for probably close to 100 years now. It used to be the mainstay of therapy. has lots of side effects. It has a narrow therapeutic index, which means what?
The dose that it works.
Toxicity and therapeutics overlap. Okay. So it can be a very toxic drug, requires serum monitoring. Has some major drug interactions. So we don't use it as often anymore. Its main action is on calcium homeostasis within that myocyte. It increases intracellular calcium concentration, so it is a positive inotrope. It's one of the few oral ones we have. So it will increase the force of contractility. So you can see why it was a useful drug for a length of time. Contraindications, other arrhythmias. It's a negative dromotropic, so it will slow down the rate of transmission through the AV node. We used to use it a lot for atrial fib. It still could be used in people who don't respond to other agents. So it slows down conduction there, increases force of contraction. So under administration, the one thing I want you to remember is plasma concentrations, narrow therapeutic range. Monitoring parameters, it is affected by kidneys. Usually you will see this used in older people. Older people, you always have to think about renal function. You always ought to know the renal function and liver status of every patient that you are going to start a drug in, because that's where you're going to get into trouble with side effects and toxic effects. The other is that potassium, magnesium, and calcium status can increase the toxicity. If they have low potassium, low magnesium, then they can become more toxic on the drug than people with normal concentrations. Digoxin serum concentration should be drawn at least 6 to 8 hours after the last dose. Okay. So this drug we dose once a day. It has a very large distribution. It means when you take it and you absorb it, then in the body it goes everywhere. It takes time for it to do that. So we're talking about distribution phase of the drug. If you So here's what happens. When you're in the distribution phase of the drug, then a lot of it's in the central compartment, so the vascular space, and it moves out into the tissues over that 6 to 8 hour period. If you check it here, what are you going to think? It's too high. I'm going to cut the dose down. Well, it's in the vascular space. It isn't exerting a pharmacologic effect. You will misinterpret it if you draw it here. So that's why we wait out to this point, then we can look to see, is it in the range that will produce the therapeutic effect we want. So that's one of the quirks to remember about DIG is large distribution phase, and you have to wait before you check it, before you check a level. Adverse effects. Mostly it's going to occur in the elderly that have change in renal function or you dosed them too high. The most serious ones are arrhythmias. Atrial arrhythmias are common. Neurologic complaints can also. They get this weird halo effect around objects. They can also have a blue-green discoloration to their vision. It's odd. I've only seen that a couple of times, and we don't use doses that high that used to evoke those as much. Usually when you get serum concentrations over 2 nanograms per ml. Most of the time, just like with the other antiarrhythmics, it's when their potassium's low, magnesium's low, Renal function is too low for them to handle the drug. And the skinny older people, they don't have as much. This drug likes to distribute into muscle. And so when you get skinnier people that don't have a lot of muscle mass, they tend to not have as big a place to distribute the drug into. Recognize that?
Yep.
So that is foxglove. This is where digitalis comes from. So the leaves of the foxglove plant contain digitalis. So in the old times, they would take those leaves, crush them up, and give them to patients. Steep them in a tea, put them in something, and deliver them. And that happened up until probably the 50s. So beautiful plant. I put it in my garden, but don't let your kids or your dogs get in it, because it can be fatal if they chew it up. Okay. Last page. So these are new in the guidelines. Address anemia. Use IV iron to replace them. You want to do it quickly? Do not do the erythropoietin stimulating agents though, so we're not going to use those. When we get to kidney, we'll be using those, but for this we want to use the IV iron. I did not check to see if these two videos are still out there. They were very good. I'd recommend them if they're still available. Dangerous meds in heart failure, non-steroidals, mostly because their effect on the kidney. Corticosteroids can be a problem. Now, for short-term use, you can still use them, but they tend to increase volume, so they can worsen heart failure. Metformin, that's a drug for diabetes. It increases the risk of lactic acidosis, which has a high fatality rate, about 30 to 40% of patients who get that diet. The TZDs, or the glitazones, worsen heart failure. They can precipitate new heart failure. They can make it worse in people who already have heart failure. The dihydropyridine calcium channel blockers, verapamil, diltiazem. Verapamil the worst. Negative chronotrope, negative dronotrope, negative inotrope. The TNF alpha antagonists, we'll talk about those when we get to RA and musculoskeletal. Especially, I think infliximab is the worst one there in terms of precipitating heart failure. And the serotonin agonists, so the triptans, they are vasoconstrictors, and so they can precipitate angina, MI, in susceptible patients. Okay. Questions about those? All right. If you all will give me till about 11, take all your stuff.